So preeclampsia, what is happening here is this is a hyperlink, okay, just like the other one, preterm labor was a hyperlink. The hypertensive disorders of pregnancy. It's not preeclampsia is a hypertensive disorder of pregnancy, but these are all hypertensive disorders of pregnancy. So we're going to spend a few minutes kind of making sure we understand the actual definitions of these different things. So gestational hypertension is hypertension of a blood pressure elevated more than 140/90 that is happening during pregnancy. Okay, that's why it's called gestational hypertension. But all it is just only elevated blood pressures. Okay, and the onset usually is past 20 weeks. That is when it is diagnosed, in fact. Okay, before that, we can't really say it's gestational hypertension. Before that, if she has elevated blood pressures, we are saying that it is chronic hypertension, this one. Okay, and what that is, okay, is normally what is happening to my blood pressure during pregnancy. Is it increasing or is it decreasing? It's going to decrease, right? Everybody should know this from normal physiological adaptations of pregnancy. My blood pressure should decrease. So if a woman comes in and her blood pressure reading is 130/80, you might think to yourself, from your med-surg self, might think, okay, that's okay, right? But actually, you got to ask yourself, well, what was her blood pressure before she got pregnant? Because if it drops, what was it? Okay, and a lot of times, women who have chronic hypertension, it is pre-existing hypertension, exists prior to pregnancy. We might not be able to diagnose her with chronic hypertension until she's done being pregnant, because I don't really have a way of knowing if this is gestational hypertension and or chronic hypertension, because if she doesn't have a diagnosis of, yes, she has hypertension before she got pregnant, in pregnancy, it ends up being a retrospective diagnosis, as in she has to be done pregnant, and then we're going to take her blood pressures, and especially at 6 weeks, by that time, even by post-delivery, okay? But like within a week, 2 weeks really, and definitely by 6 weeks, her blood pressures have normalized, okay? Just like with gestational diabetes, something that happens only during pregnancy. So if gestational hypertension only happens during pregnancy, then when she's done being pregnant, her blood pressure should go back to normal. But if it doesn't, then retrospectively, now I'm saying, no, her blood pressure is still elevated. This woman had high blood pressure before she got pregnant. And this is important to know because, you know, if we were like in a normal class, I would point to someone sitting in the front row and say, do you know if she has high blood pressure right now? Can you tell if someone's just sitting there, they have no symptoms, right? Are there symptoms of pre-hypertension, you know, right? That's one of the categories, right? Hypertension, pre-hypertension. There really aren't any symptoms. So someone who's young, normal, healthy may actually have pre-hypertension and or hypertension, and we might not know about it, because why else would she have to go to the doctor? She's only 25 years old and she feels healthy and fine, right? You guys following me? Okay, and you know, I mean, we have universal health care, I guess we do in the US, but maybe not everybody does, and everybody maybe doesn't go to the hospital. And for a lot of women who are young and healthy, one of the first times they're gonna go see a provider is for pregnancy, and the only time they will have never been hospitalized ever before. The very first time that they're gonna go to the hospital for anything is to have a baby. Before that, they had no reason to go to the hospital. Okay, so you have to know that. And so what then is preeclampsia? Preeclampsia then is elevated blood pressure with protein in your urine and or some other organ system that's being affected by what is essentially causing preeclampsia. And we're going to talk about that in a second. But that also is diagnosed after 20 weeks of pregnancy. So it's not only just high blood pressure. Well, in fact, it's blood pressure above 140/90. And in addition to that, I am seeing other end organ damage. Okay, essentially protein. But preeclampsia can also be diagnosed without protein. If you have other features of preeclampsia, you can be diagnosed with preeclampsia and not have protein in your urine. It's rare, but it's not an absolute. Recently, it was changed. Okay, it is not an like a headache. Yes, it is not an absolute. If you have to have protein in your urine to be diagnosed with preeclampsia, that's not true. It used to be the diagnosing criteria, but it's not the anymore. I'm pointing that out because depending on what you read, it might tell you different things, and that's going to be reflected on my slide later, which actually is reflected on this slide, but not on yours. Maybe I'll repost these. Not really. Okay, and then preeclampsia, if it's not treated, okay, we just ignore it and she keeps having high blood pressure and there's end organ damage with protein in her urine and other organ systems that are being affected, we ignore that. It's going to lead to eclampsia, which is preeclampsia with neurological symptoms and or a seizure. Essentially, it's that woman's blood pressure is so high, she comes in with a blood pressure of 210 over 140, seen it, okay, and she has a seizure, seen it, okay. So that's eclampsia. Right. So then what is this thing called preeclampsia, eclampsia superimposed on chronic hypertension? Oh my God, sounds so confusing, right? Well, so what that is in addition to having chronic hypertension, now she also has preeclampsia that's superimposed on it. Sort of like what it says. You also have to not only fixate on the number, the blood pressure reading. Oh, it's above 140 over 90. You have to look and see if the reading is more than 30 and or 15, the diastolic and systolic from your baseline with onset of significant proteinuria. So it doesn't meet that 140 over 90 cutoff, okay? Like it's 130 over 80. But she has protein in her urine and or other organ systems are affected. So we're going to talk about those other organ systems in a second. If those things are affected and her blood pressure is not at 140 over 90, but that is called chronic hypertension superimposed with preeclampsia. Okay, so you have to be careful when your blood pressure reading goes up that much from your baseline. You have to be vigilant about that. You don't want to ignore it. Okay, so those are all the types. And then on here is HELLP, which is not on this like little graph thing, but HELLP is like preeclampsia's cousin. Okay, it's a variation of preeclampsia. We'll talk about what that is specifically. Your ATI book, I know I said I'm not this huge fan of the ATI book, but that chapter on this stuff, which is what chapter is it? You'll find it. It's actually really good. Okay, I want you to definitely check it out.
Learning.
Huh? One more time. Someone was saying something, but then I don't know what they were saying, so I'm gonna move on. Okay. So management of hypertension in pregnancy. Well, I'm going to talk about that in a second, but 2 to 7% of pregnant women are going to be affected with preeclampsia. And of those, 5 to 8% of these women are going to develop what's called HELLP syndrome. And that's a variation of preeclampsia. I'm going to talk about HELLP syndrome in a little bit. Medical management, if it's acute, okay, she walks in and her blood pressure is 190 over 130, okay, I'm going to have to give her IV labetalol, IV hydralazine to lower and initially just drop her blood pressure. Okay, and then we're going to, if it's maintained and it's stabilized, maybe we can continue oral therapy, but usually we're also going to give her magnesium sulfate to make sure she doesn't have a seizure. Okay, and that's how we're going to manage it. There's more on this. I feel like the slide should be like a few slides later. What causes, okay, preeclampsia? So let's talk about that a little bit. There's a reduced organ perfusion secondary to vasospasm and endothelial damage, okay, maturation that's happening. Other organs are going to be affected by this, okay? Hepatic, renal, coagulation, central nervous system, pulmonary, fluids, electrolytes, the eyes. We don't really know what is happening till later, okay? But what's happening is we can't really diagnose it till after 20 weeks, I said, right? But pathologic process of preeclampsia is most likely happening early on in pregnancy. And why exactly this happens, we don't know exactly why. We think there's a genetic component associated with it. We haven't really figured out the exact why just yet. But it is, most theories are leading to abnormal placentation as the reason for preeclampsia, okay? So what, sorry, you can see from this photo, okay, so this remodeling of the uterine vasculature involves the replacement of the smooth muscle layer of the spiral arteries. Okay, the arteries go in and they embed into the endometrium and they dilate. Okay, and something is going on with abnormal placentation where this dilation is not happening and the spiral arteries can stay constricted. Okay, so the spiral arteries are being replaced in larger capacity, they're dilating, and the resistance is being lowered. That's why her blood pressure will also drop in pregnancy. Okay, and this results in increased circulation. So increased placental circulation with the spiral arteries like dilating out. All right, and oxygen to the fetus is increased as a result of this. Incomplete transformation of the spiral arteries occurs with preeclampsia. So something is happening again. We don't know what that causes this not to happen. Cytotrophoblasts invade the decidua of the spiral arteries, but not the myometrial portion of the artery. Okay, and this shallow invasion leads to narrow vessels with high resistance instead of low resistance. So when low resistance happens and the dilation occurs appropriately and they're embedded appropriately into the decidua, okay, the resistance drops and her blood pressure drops. But when it's constricted, okay, the resistance is high and thus her blood pressure is going to go up. Okay, this high resistance then leads to poor placental perfusion. And poor placental perfusion, you can see, is going to affect the baby and the growth of the baby. So a lot of times, while we see generally LGA, like large for gestational age and big macrosomic babies, in the cases of gestational diabetes, with gestational hypertension, we're more likely to see intrauterine growth restricted babies because you see what's happening. Perfusion to the baby is not at its optimum. Okay, so that being said, all right, suboptimal placentation and the decreased ability to perfuse is going to trigger this inflammatory response in the body, and it's going to result in the release of pro-inflammatory cytokines, okay, C-reactive proteins, interleukin, all of these things that are going to lead to this cascading effect of endothelial damage. So the lining of those blood vessels that are constricted is going to get damaged and vasospasm is going to start to happen. And activation of the coagulation system is going to start to happen as a result of this abnormal placentation. This is a good theory. I feel like it doesn't explain why then we see preeclampsia symptoms in a mom who's delivered, placenta is out, essentially. So the treatment, there's no real treatment for preeclampsia. We're going to manage it, and then we're going to treat it by delivering the baby and getting the placenta out, because that's the problem. Okay, but then one of the worst times that I've seen preeclampsia actually is not always the case, but it can happen actually up to 6 weeks postpartum. And the argument then is that the cytokines and the C-reactive protein and coagulation cascade that essentially started to happen and is off balance, and the endothelial damage, it continues to happen even though the placenta is already delivered. Okay, but I had a woman who came in, I think her baby was already like a week old, African American, slightly obese. She walked in with a blood pressure of like 230 over 140, and we gave her all the IV medications that we could to lower it. We put her on magnesium sulfate. We like did everything, and nothing was bringing down her blood pressure. Okay, thank God she didn't have a seizure. But I was like, what do we do now? We like gave her all the meds we could possibly give, and the resident was like, "Oh, we're gonna probably transfer her to the ICU for pressors and IV drip because there's nothing more we can do on our level here." So finally, her blood pressure dropped to like 160s, 150s over 90s, and we're like, "Okay, we'll take that." But slowly, it came down. But it's really scary when you see it. Okay. So what's happening, okay, with this abnormal placentation, all right, is that it affects other organ systems, okay? So here's some more info here. You can read through this slide. And so risk factors for preeclampsia are going to be first pregnancy, woman older than 30, history of high blood pressure, obesity, diabetes. Those are linked. Okay, remember with diabetes is linked to preeclampsia. Obesity, this is going to be linked here too. Okay, preeclampsia in the previous pregnancy, and or sometimes it's not listed here, is a new partner. It's just, they didn't have it, but then all of a sudden she gets pregnant from a different person and she has preeclampsia. So there is some linkage with like the way sperm and egg and all of those interact. I'm talk about these signs and symptoms. What you don't have in your uploaded slides is this thing with the preeclampsia with and without severe features. Okay, and I wrote a note down there. I think I'll just repost these slides for you guys to reference for when you're studying. Thank you. So on here, it has preeclampsia severity. So thing called like mild preeclampsia and severe preeclampsia. And essentially it's broken down with how high your blood pressure is, right? It's blood pressure 160, less than 160. If your systolic blood pressure is greater than 160, then it's under severe. If diastolic blood pressure is greater than 110, then classified as severe, and then it has something to do with how much protein. New research shows that actually protein, the amount of protein doesn't really matter as much, and protein in your urine is not this absolute diagnostic criteria for preeclampsia. That being said, the new terminology when we're talking about preeclampsia is not so much the elevated blood pressure. A blood pressure above 160 over 110 is in itself a severe feature. But along with that, okay, severe features is referring to a headache, okay, blurred vision, epigastric pain, hyperreflexes, yes, more than 5 grams of protein in her urine. Usually we don't even wait for 24-hour sample collection because we might not have time, although that seems to be the gold standard. What is recently being done, and this is being done in other units and other, places like MedSurg or oncology or whatever, we would do a protein creatinine ratio. All right, so that's like the new standard, but it's not part of all protocols and everywhere just yet. So we're going to look to see how this woman is presenting. So she might have preeclampsia with and or without severe features, and I'll include that in the notes. Okay, I have like these 2 links with commonly asked questions. I think it's nice to look through. But what's happening? You're going to see an elevated blood pressure in this woman. She's not going to come in saying, I think my blood pressure is 190 over 110. She's not going to do that. She's going to come in saying, I have a headache. She's going to come in saying, I have blurred vision. And we're going to talk about what is causing these things. She's going to come in with, you're going to take her weight, and 2 days ago she was 150 pounds, and 2 days later she's 154 pounds. You don't gain 4 pounds in 1 or 2 days, okay? What's happening is there's fluid that is third spacing. We're going to talk about how. She's going to come in complaining of epigastric pain, okay, and or blurred vision. Those are all signs that she's going to say. That'll lead you to think, let me take your blood pressure because you might have preeclampsia. And in addition to taking her blood pressure, you're going to check to see if there's protein in her urine. You're going to check her weight, and you're going to do DTRs, deep tendon reflexes. Okay, and I'm going to tell you why in a second. So this concept map is out of your book, and it's really good to go over, and I want you to do that. Okay, so this endothelial cell dysfunction, right, the lining of my blood vessels is going to be damaged. And what that's leading to is increased permeability and capillary leakage. It's breaking down. And when there's leakage and permeability, where protein is going to leak out because those blood vessels are going to be damaged. So your platelet levels are going to go down because the platelets are trying to come and block off that leaky blood vessels. Okay, so the platelets are going to be taken up, but that's not really going to work. And while that's doing that, protein is going to come out of the blood vessels, and where protein goes, fluid goes. So she's going to third space, and she's going to look like she has generalized edema. So not just edema in her legs, okay? Proteinuria edema here, but also generalized edema, periorbital edema, facial edema. Her little ring, she cannot take it off. That's not normal, okay? There's so much third spacing happening, okay? Intravascular coagulation is going to happen because Anyway, I want you to read through this, and when you watch the videos, the hyperlinks, it's going to do a much better job of explaining to you. The vasospasm that's also going to happen is going to cause liver ischemia. That's going to lead to the nausea, vomiting, and the epigastric pain. Okay, the retinal arterial spasm is going to happen. It's going to cause the blurred vision, but also blurred vision is going to come because of all the edema that's happening in her brain. Okay, when there's so much edema, right, and she's swollen everywhere, there's also cerebral edema. Okay, edema in my brain, and all swelling is going to cause me to have that headache. Okay, all that swelling is going to cause me to have blurred vision. And all that swelling, when you do her DTRs, you're checking her central nervous system, right? And they're hyperflexing 3+, 4+ DTRs. That's not normal. And that is telling you that she is one step away from having a seizure. Okay. 4+ DTRs, her blood pressure is 200/130. She has a headache. Those are severe features with elevated blood pressure. You'll check her protein, she'll be spilling protein. Why is she spilling protein? Okay, so in 70% of the cases, they're gonna have protein in their urine. Okay, and normally the glomerular filtration rate is increased in pregnancy, but with preeclampsia, because of the vasospasm and the vasoconstriction and the less blood supply happening in the constricted arteries, her glomerular filtration rate, the renal plasma flow, is going to be decreased, and her glomerular filtration rate is going to be decreased also. And so then her kidneys are going to have a harder time clearing out the protein, and she's going to get proteins that's going to be secreted in her urine, which is not normal. Okay, uric acid, creatinine, calcium clearance are decreased. Okay, and she's going to have oliguria. And so what is the definition of oliguria? Urine less than how many milliliters per hour? 30. Perfect. So oliguria is a sign of worsening preeclampsia, okay, and kidney damage. All right, so her liver could be damaged. Coagulation cascade is going to be damaged because of the damage to the cell lining, and all the cascade is going to take place, which we'll talk about. The video does a nice job of explaining it. So I'm going to go a couple minutes over and just finish out here on preeclampsia and how we manage it, okay? For like another 10 minutes, I'm going to talk and end the lecture. But I do want you to check out, okay? So, pulmonary edema can also happen from the volume overload related to all the third spacing also. Okay, so you have to be very vigilant with these patients, and it can turn the corner very quickly. That's why they're very like aggressive with preeclampsia. It's not something I'm just like, oh, it's okay, it's just white coat syndrome, let's see. But it's not like that. All right, so that being said, this red one is Dr. Hartman's kind of concept map on preeclampsia. So these anti-angiotensin from the placenta, okay, cytokines that the inflammatory markers, cytokines, right? C-reactive protein and all these things that cause fibrin deposits to form and vasospasm to happen, causes renal damage, causes liver damage, okay? So the decreased oxygenation to the liver is going to cause liver damage. It's going to lead to that epigastric pain, okay? Hypertension is going to lead to the headache from all the cerebral edema. Okay, we can give her antihypertensive. Glomerular damage is going to be decreased. Protein in her urine, and edema, blurred vision, hyperreflexes, cerebral edema. So this is sort of her concept map. I want you to watch the 2 videos that I've included for preeclampsia. It's not letting me log out. It's okay. I will log people out. I see that there is, how do I have 26 attendees? That's kind of weird. Oh yeah, I'm supposed to have 28 and 2 people just left. That's fine. Everybody is still here. So I'll check people out. Don't worry. Okay. So the preeclampsia is, a big deal. How are we going to manage it? If she does have like mild blood pressures, right? Her blood pressures are not in that severe range of above 160, above 110, okay? Immature fetus, if the baby is if this preeclampsia it tends to be more severe as pregnancy progresses, okay? That's why we check her blood pressure, and that's why we're seeing her more frequently towards the end of pregnancy. But we might put her on bed rest, we might give her hypertensive therapy, oral labetalol, oral hydralazine, oral calcium channel blockers that may work, okay? Then, if it's severe, we're going to have to give her magnesium sulfate. And the reason for the magnesium sulfate here, we're going to give her a loading dose, as in I'm going to give her a large amount of magnesium all at once. The loading dose usually goes in within 20 minutes. So in 20 minutes, I've loaded her body with 4 grams of magnesium. That's a lot of magnesium. Okay, and preterm labor, we give magnesium sulfate also, and we do a loading dose, and that one is usually 6. So again, depends on what institution you're working at. But within 20 to 30 minutes, I've given her 4 grams of magnesium sulfate. Well, what that's doing is the goal and the indication for magnesium sulfate for preeclampsia is to prevent a seizure. And so it's going to oversaturate the cells, that amount of magnesium, and it's going to prevent calcium from coming in, and it's going to prevent a reaction from happening and from her from seizing. Okay, and what it does is it also relaxes the uterus. So that's why in preterm labor it can work as it's going to delay the birth, because it's a uterine it's a muscle relaxant, and the uterus is a muscle. After that, unlike preterm birth, where we're only giving it usually for 24 hours, we're going to give her a maintenance dose, because just because I gave her a loading dose and I prevented her from having a seizure right now, if I stop it, she's still at risk for a seizure. Okay, so I'm going to give it to her continuously, usually at 2 grams per hour. I know it says 1 to 3, but usually it's 2 grams per hour until delivery. Okay, she's on this MAG. It's a nasty drug to be on. Antihypertensive, induction, or C-section, depending on what the baby is doing or how severe things are. Okay, but you don't want to just sit on this. So if she is on magnesium sulfate, I'm going to assess her deep tendon reflexes. Okay, because now they were going to go from +4 to +3 to maybe being +2 or +1. You don't want them to be absent. That means you're giving her too much magnesium sulfate. I'm going to assess her respiratory rate. It should be somewhere between 12 to 20, right? If too much of the muscle is being relaxed and the diaphragm is a muscle, then it's going to lead to respiratory depression. So I need to make sure this patient is still breathing 12 breaths per minute or higher. Listen to her lung sounds. Okay, urine output, watch for it, because it could be decreased, but as things are getting better, her urine output should increase. And I'm going to check her level of consciousness. Okay, you're going to stop the infusion if symptoms of toxicity occur. So I'm giving her too much magnesium. So I'm going to teach her what to normally expect from this mag sulfate. And she's going to feel a lot of warmth and flushing, especially that loading dose, that you're just going to feel like heavy head, soft cottony, like just congested she'll feel. Burning at the IV site, mild shortness of breath, maybe mild chest pain, maybe okay, but you got to watch and make sure it's not going down the wrong path. Congestion, headache, dizziness. Well, now is her headache due to the magnesium sulfate, or is it due to the fact that she's on MAG? Okay. Also, it is a central nervous system depressant, right? So it's going to prevent a seizure from happening, but also you're going to warn this patient that is a muscle relaxant all around. So she's not supposed to really get out of bed and walk around and go to the bathroom, because now she's at risk for falls. So she's most of the time going to be on strict eyes and nose, because I want to make sure that her urine output is above 30, and I want to make sure she doesn't get out of bed. So I'm going to be watching, making sure what's going in is coming out. You don't want to give her too much fluid, right? So you're going to watch how much, and no more than 125 milliliters per hour through her IV, because you don't want to enhance that uh, um, pulmonary edema. Okay, and if I am worried about magnesium sulfate toxicity, I'm going to stop the infusion, and the antidote for it is 10% calcium gluconate. IV push over 2 to 3 minutes, 10 milliliters. That's how much you're pushing. Okay, so you got to know that. All right. And I want you to realize that when the patient is on magnesium sulfate, the toxicity, this is, we just went over this. Urine output, respiratory rate decrease, patellar reflexes are absent, okay? Her level of consciousness is going down. You want to know and understand that when I'm giving this patient magnesium sulfate, okay, sorry, let me check the chat. I gotta go. I work tomorrow. That's fine. Log out. I just want to finish this thought on preeclampsia before I end my lecture. You listen to it later. So what I want you to understand though, that I just loaded her with magnesium. I am wanting to give her body a certain amount of magnesium, okay, to prevent the seizure. That is the reason we're giving her magnesium sulfate, okay? And when I'm giving it to her, if I were to check her blood glucose, blood levels, okay, for magnesium, the therapeutic level is telling me that the drug is working and she's not going to have a seizure. It doesn't mean she'll never have a seizure. Never say never, because even though they're magnet, they can still seize, okay? But it's significantly decreased. I've never seen someone on magnesium sulfate actually have a seizure, but it doesn't mean it doesn't happen. All right, so 4 to 7 is the therapeutic level for magnesium sulfate. All right, that is not a normal value for magnesium levels in your blood. Okay, right? You know that? But if she's on mag, this is where it should be. It's telling me it's working. At our institution and a lot of places, we don't do mag levels. We just know that if they're got their bolus dose and they're on maintenance and they don't have any of the signs and symptoms of toxicity, I don't need to check her magnesium level to know if it's within therapeutic range, because that the protocol says it should be if you're giving it to her in that way. And I don't need to check it to see if it's out of the therapeutic range, because she doesn't have any of the signs and symptoms for it. So you, as a nurse, are vigilantly watching for it. And some places do draw a mag level. Okay, so it depends. But you got to know that if the mag level is over, 8 to 10, it's gonna cause uterine relaxation. 10, the reflexes are going to disappear. If it's 10 to 12, you're going to start getting respiratory depression. And if it's more than 10, you're going to have respiratory paralysis. Okay, like you missed all these signs if it's more than 12. Dr. Hartman tells this very sad story of a new grad nurse who was working with her preceptor, and her preceptor had this other patient and walked away for whatever reason. And the new grad nurse constituted the magnesium sulfate. And at the time, they had to like mix it in themselves, and the pharmacy wasn't doing it. We didn't have these fancy pumps and computerized charting where you have to like scan the medication. We're so advanced now. And magnesium sulfate is double checked by a nurse always. Okay, so I hang it, I program it through the IV. There's a way to ensure that all the ports are correct, and the pump is correct, and the reading is correct, and the computers are correct, and I have the right patient and the right dose and the right route and everything. And then another nurse comes and she checks all that, and then I press go on my IV pump. Okay, but for whatever reason, this student constituted it twice the amount, and the patient had respiratory paralysis and died. Okay, that is probably not the only time that that's happened. Okay, but she actually was there when that happened. So sad. All right, and if we don't control preeclampsia, it's going to lead to eclampsia, which is essentially a seizure, which is why she's getting the magnesium sulfate. Okay, we're going to maintain the airway, understand that when a mom is having a seizure, it's going to affect the baby. So you're going to continuous fetal monitoring, monitor for possible abruption, because if she has a seizure, then her placenta might abrupt. Okay, vaginal bleeding, non-reaching fetal heart tones. You're going to stabilize and deliver them all. Okay. HELLP syndrome is, again, I said, the cousin of preeclampsia. So this is when we have, it's a complication of preeclampsia that 4 to 12% of women will have. Signs and symptoms: nausea, epigastric pain, generalized malaise, right upper quadrant tenderness, visual changes. Those are signs and symptoms, all same as preeclampsia. In order to diagnose HELLP and to say that the patient has HELLP syndrome, you have to have hemolysis, elevated liver enzymes, because the liver is at play here with the HELLP syndrome, and low platelets. What's happening is when coagulation is affected and the platelets are being all used up from the endothelial damage, there's low platelets. Okay, so less than 150,000. And with all these, like, there's little microthrombi that's happening in there also. Fibrogen split factors are happening. Something is activating the coagulation factor. And normally, blood is going to be able to flow through those blood vessels. But when they're constricted and there's blood clots everywhere, they're kind of going to go through and they're going to break down. Okay, they're going to hit up certain things, and hemolysis is breaking down of the red blood cells. So you can't really diagnose that with an H&H, but your hemoglobin and hematocrit is low. It's like a quick and dirty way of saying I have hemolysis. But essentially, you need a smear. You need to do a red blood cell on a smear in the lab to see hemolysis. All right. So if you have this specific diagnosis of hemolysis, elevated liver enzymes, and the liver enzymes I'm looking at are the AST and the ALT, and usually they're twice as elevated, so twice as much as what your normal baseline is, but they could be like as high as in the 400s, 600s. Low platelets, that is how you diagnose preeclampsia. Okay, so that is a precursor for DIC. We're going to manage that, and DIC is a disorder of clotting cascade. You can read through this. Hypercoagulability is going to happen as a result of DIC. Okay. Pregnancy presents a state of accelerated but compensated intravascular coagulation. Okay, but in DIC, when it's resulting from, these are certain risk factors, okay, from CIS, from severe preeclampsia, HELLP syndrome, where a lot of my clotting factors were already used. Retained fetal demise is another big thing that can predispose someone for DIC. Okay, something is activating the coagulation factors. Normally, the pregnant mom has increased levels of fibrinogen, so she doesn't bleed postpartum. Okay, but our clotting factors are circulating as precursors. So, like active fibrin is circulating through our body. If I cut my arm, the thromboplast activates the fibrin, and then a clot is formed. But generally, something has to happen in order for the thromboplastin to activate the fibrin. Okay, so as the clotting factors are activated, we don't turn into like the giant big clots, right? You have microthrombi that circulate throughout the body and can clog up the lungs and the kidneys when DIC is happening. So we're going to check to see if she has activated fibrin. So if there's activated fibrin, it tells us that something is wrong. Okay, and with DIC, she'll have fibrin split products, and the normal ratio is 0. Her D dimer is going to be off. Something is going to trigger it that's going to consume your clotting factors and your platelets, and the blood's not going to clot properly because the whole cascade is off. So I want you to watch the videos that I've provided for you for the DIC. Okay, this slide talks about it. This slide talks about it. Your nursing assessment is you have to be able to identify underlying causes, sepsis, fetal demise, hemorrhage, okay? And hemorrhage, she's lost too much blood to be able to clot. Monitor for signs and symptoms of bleeding, petechiae. She's going to have like easily bruising, bleeding out through her IV site. You have to be able to assess and know what the signs and symptoms are listed here, right? Don't disturb the blood clots, okay? Obtain lab tests, inform the doc, okay? And amniotic fluid embolism, you can look through this, it's super rare, but I also have a video on this in your study guide that I want you to refer to.